thank you, WIROC, for giving me this opportunity, and the Bombay Orthopaedic Society for inviting me. And my topic is bone substitutes, allografts. Everyone has a role. Now, over 2 million patients a year need some sort of bone grafting procedure to fill bone defects or induce osteogenesis for treatment of non-unions. But there are multiple issues with bone grafts, so there is an increasing demand for other bone graft sources. These substitutes are used as extenders for large defects, enhancers to improve the success rate, and substitute the autogenous bone graft. They use in multiple situations: oncology surgery, traumatology, revision prosthetic surgery, spine surgery, etc. Some terms that we should know include osteogenesis, osteoconductive, osteoinductive, and osteopromotive. An ideal bone graft substitute should be osteogenic, osteoinductive, osteoconductive, should be biocompatible, bioresorbable, should provide structural support, should be easy to use, and should be cheap. So coming to allografts, here is a situation of an allograft which has been used to provide structural support in a revision hip surgery, and you would see that the allograft from the femoral head has been sculpted and fixed to the native acetabulum, which now accommodates the acetabular cup very stably. It also can be used, the allograft can also be used to provide mechanical support for depressed fractures of the tibial condyle. Bone graft substitutes available and popular today include calcium sulfate, phosphate, injectable pastes, demineralized bone matrix, etc. They are available in various forms and various sizes. Now, the resorption rate varies widely. Calcium sulfate, which has a very rapid, within 10 to 12 weeks, it would be resorbed, as opposed to calcium phosphate, which takes 6 to 10 months, 12 months to resorb. And you could combine these to optimize your resorption rate. The porosity and the geometry determine the mechanical properties. A word about these substitutes, each of them. So calcium phosphate is also available as an injectable paste, which has a very high compressive strength, which could allow early mobilization and weight bearing as well. Calcium sulfate, which resorbs very rapidly, gives no structural support, has a very low compressive strength, used for void filling and also as an antibiotic carrier in situations of infection. Bovine collagen is used with bone marrow added to it, bone forming cells, and this could be used for collagen-based matrices. One of the more popular ones is the demineralized bone matrix, which is available as gel, putty, etc., and can be combined with cancellous bone, allograft as an enhancer also. The marine coral exoskeleton is used to produce hydroxyapatite, which has the structure just like spongy bone, that is the cancellous bone, but the positive thing or the negative thing, the property is it resorbs very slowly. One of the more popular tricalcium phosphate is a synthetic, osteoconductive, osteoinductive, and it is one of the more potent bone graft substitutes. Platelets release a lot of growth factors which are osteopromotive, and they are becoming more and more popular because of its low cost, autologous nature. But remember, they are not truly osteoinductive. They need an osteoconductive agent in addition to the fact that they lack mechanical strength. Bone morphogenic proteins, again, BMP2 and BMP7 are two more researched products, and BMP2 has been FDA approved for open tibial fractures as well. So now coming to the main part of the presentation, now you have to ask certain questions. Does this graft substitute offer structural support? Is there an injectable application? What is the speed of resorption? And most important, does it meet the burden of scientific proof of efficacy. So let's see this case, fibrous dysplasia, 24-year-old male, and you will see that there is a void in the, there is a cystic defect in the supraacetabular region, structural defect nearly coming to a fracture of the neck of femur, which needs void filling and structural support and splintage below as well. So here what I have done, I've used the cancellous allograft because a lot of graft is required. And it is a difficult proposition for anyone. So cancellous allograft has been used with tricalcium phosphate crystals to fill up the supraacetabular defect. I've done a prophylactic nailing. I've used the autogenous fibrillar graft in the neck of femur, and I've used autogenous bone graft with TCP crystals, that is tricalcium phosphate in the distal part of the neck. Another case, well, very commonly done, open wedge proximal tibial osteotomy, a wedge-shaped tricalcium phosphate. These wedges come in various sizes, and you can exactly use it to the size you require. Another place where everyone uses very frequently is structural support for the depressed condyle fracture, and here bone cement has been used as to elevate, and that's your fixation. Another case, this is a doctor, 34-year-old, posterolateral depression, and this has been elevated. So the question you ask is, do you need structural support or do you need a void filler? So of the two, and where does osteogenesis come? So to summarize, you match the need versus what you want, what is available. So if you need cortical support, cortical allograft is a good option. If you need a spongy or a void filler, there are multiple options which include calcium triphosphate, DBM, etc. If you need a moderate rate of resorption, calcium, just half a minute please, calcium phosphate preparations. If you need rapid absorption or antibiotic carriage, calcium sulfate is good. Slow resorption if required, hydroxyapatite. If you need it as a bone extender, the bone graft substitutes, allografts, DBS, etc. So, to the topic that has been given, allograft and bone graft substitutes all have a role to play. We have to understand our need and our availability. Thank you.